So I'd like to introduce our next speaker, Dr. Jennifer Bailit, Executive Director of the Women and Children's Patient Care Unit at the Metrohealth Center, Metrohealth Medical Center. Let's welcome Dr. Bailit.
So, no conflicts. So I always like to start a talk with what we're going to do in this talk, so you can know when to fade in and fade out. I'm part of the Ohio Perinatal Quality Collaborative, and you'll also hear from Jay Imes in a little bit about some other work with us. But we're going to talk about what the OPQC is, what are its goals, why it's needed, how does it work, how well does it work, and what have we learned. So the Ohio Perinatal Quality Collaborative is a group of hospitals in Ohio, needless to say. There are about 20 of us in the core group, and that has spread out over time. It started with almost all of the level 3 hospitals and many of the level 2 hospitals in the state. It was initially funded through CMS, and it was considered to be a demonstration project. And what was unique about it was that it really put OBs and the pediatricians in the NICU together to fight prematurity together. And it sort of referred to as what a long, strange trip it's been, because how this got started is Ed Donovan, who many of you know, who has since retired, and Jay Imes got in a car and literally drove around Ohio doing grand rounds at various hospitals, convincing people that we needed to do this. And that's how I got hooked. They came to give grand rounds, and I raised my hand and I said, I'll volunteer, and next thing you know, I'm here in Washington, D.C. talking about it years later. So it really was very much a grassroots effort. I think part of the reason it worked so well is between Ed and Jay, they had trained most of the OBs in the state, so everybody knew them, and everybody wanted to join them. There was a huge leadership piece to this. So the goal of OPQC was to reduce prematurity-related perinatal mortality and morbidity quickly, emphasis quickly, by applying quality improvement techniques to prenatal, interpartum, and neonatal care. So how do we change practice? We know from previous works that CME really doesn't work. I try to make this argument every time I get those requirements in the mail every year. Nobody ever seems to want to listen to me. But the evidence would say CME does not work to change practice. Academic detailing does. I think of that as the drug rep model. You know, somebody comes to your practice, they bring lunch, they talk to you about the latest and the greatest. That model works very well, but it's very resource intensive. So we really need to bring a new twist to the game. Because what we're doing currently to spread innovation doesn't work, and so we need a new game. So you guys remember the scene from Indiana Jones? The guy comes out and he's waving the knife around, and his big show of skill. And Indiana just looks at him, pulls out a gun, and shoots him, right? You bring a new weapon to the fight, it changes everything. So what's our new weapon? Our new weapon is basically based on audit and feedback. And this is a technique that has been shown to disseminate new information well. And so what is audit and feedback? It's essentially this, right? You do something, people rate you, you try it again, hopefully your ratings go up. So, on a more serious note, it's information that's gathered about a physician or a hospital. I actually want to put in a plug here that we really should be probably at the hospital level, at minimum the practice level, because when you look at individual physician level for this kind of stuff, the numbers are inherently unstable and meaningless because there's just not enough volume that any one person does. So the information is gathered about the practice. The information is collated centrally and returned in a comparison to what other people are doing. And that is essentially the underpinning of OPQC. It really sparks on people's competitive nature. You never want to be less good than the guy next to you, especially if you're in competition with them. So what it does, and I'll show you in a minute, it'll give you a graph with your name on it. Everybody else will be on that graph. You just don't, it's unlabeled. So we don't actually share what other people are doing. You don't necessarily know who your competition is on that on that graph, but you know that you're doing well or not doing well. So what does the OPQC do? It gives structure to collect the data. It has standardized data collection sheets. It encourages people to download that data centrally. OPQC does the analysis and feeds back the graphs. It also gives suggestions for possible areas of improvement, and it's a key driver diagram, and I'll go through that in I believe, the next slide. OPQC keeps a central record of what the various hospitals are trying to do. So, for example, our first project was the 39-week project, and then we did antenatal steroids, and I'm going to talk more about that project in a minute. But we kept track of a little bit about who was doing hard stops for 39-week, who was doing patient education, so that we could kind of talk about what was working and what wasn't. They give support for these efforts. So there are monthly phone calls where people compare what they're trying, what's working, what's not working, what the barriers are, so that not every single center has to recreate the wheel. You can learn from your fellow hospitals. And it gives feedback, which is those graphs that we spoke of. So this is a key driver diagram. Let me see if I can get the, okay. So there's a global aim here, which is to assure that all infants born between 24 and 0 and 33 and 6 weeks gestation receive appropriate antenatal corticosteroid treatment to reduce perinatal morbidity and mortality. That's the sort of overarching aim, and then what we call the SMART aim, or where the rubber hits the road, is to increase the percentage of infants born in Ohio, 24 to 33 and 6, who receive pre-delivery antenatal corticosteroids to greater than 90% by June of 2013. So here were the things that we thought might be key parts to the system. So documentation system. We weren't sure that the data we were getting back was accurate, right? So OPQC also has access to all the birth certificate data in essentially real time. I think there's a week or two lag. And because we work with the state vital stats. So we can get what we call hand-collected data, where somebody's actually going through charts or talking to patients or whatever it is. That's sort of the higher quality data, and we can compare that to the same hospital during the same period from the birth certificate data. So we thought there might be some issues with the birth certificate data here, and then the interventions were very specific to how to influence this. So for example, standardized birth certificate documentation of ANC administration. When we started digging into this, we realized there were 1,002 ways that people were coding their birth certificates. Some very trained people who did them all the time. Other places it was rotating secretaries. It just completely depended, and that variation was therefore a target for how to improve data quality, for example. And I'm going to look at this one here, identification of appropriate time for ANC administration. So choose an ANC guideline or strategy for your site. I was just having a conversation with Dr. Imes in the back here. We essentially started by trying to have, I think it was 4, different kinds of strategies for giving steroids. Some more aggressive, some less aggressive. We couldn't get 20 hospitals in Ohio to agree on picking one of 4. Okay? That's with lots of enthusiastic participants. The nuance there was just too great. The protocols had things like, if you think the patient's going to deliver in less than 4 hours, the next one might say 6 hours, the next one might say 12 hours. But we couldn't get people to sort of commit to that one way or the other. There were other nuanced things that they wanted to be able to incorporate it into that. So we were unable to get it standardized. One of the things that's nice about OPQC, it's easy for me to say, right, is that all politics are local, right? We're not going to tell you how to do this. We're going to tell you the goal. We're going to give you the data to do it, and then you're going to figure out what the issue is at your hospital. And that gives people tremendous freedom. They can try something, they can throw it out, they can do something else. So, I guess I skipped ahead here. All politics are local. OPQC does not tell centers how to improve. We're fond of saying we are not the OPQC police. We're not going to come to your medical center and slap you in the hand. This is not a research protocol. There are no protocol violations. All we're going to do is give you the data and say, ready, set, improve, go, and help you get there. But you're going to have to do the local work of figuring out what the barriers are. So at each hospital, you choose your own intervention. OPQC provides the data on whether it's working or not, and we also give you both the hand-collected data and the birth certificate data. And we work on PDSA cycles. This is the IHI model of improving quality. You need to know what you're trying to accomplish, How will we know that change is an improvement? That's the measurement piece. And what changes can we make that will lead to improvement? And essentially, we do these rapid cycle plan, do, study, act again and again. It might be little tiny things. When I first started doing this as a sort of hardcore researcher, these drove me absolutely nuts. Poor Jay had to pull me up off the ceiling a couple of times because I would say, you can't give a survey to 3 people and call that a plan. Yes, you can. You're just testing, right? You're not looking to solve the world in one intervention. Rapid cycle, little things. You know, you might try to get the sonographers all to put the measurements on the pictures for a couple of days. Can you get that to be done? Okay, great. If that isn't able to be done, why not? Talk to some folks. Okay, now let's really try to do this. You can start with little tiny pieces. So this is the hand-collected data for the steroids project. The first thing you ought to notice is that on almost every OPQC graph, the numbers are completely unstable for the first couple of weeks of the project. That's having a lot to do with people getting their IRBs up and going, data use agreements, incomplete data collection. So usually there's a rapid period of instability, but then you can see it's evening out pretty carefully here. And you can see also that 90% is this red line. Well, guess what? After the first month when everybody was reporting data, we were already above 90% from the very get-go, okay? This is hand-collected data. This is high-quality data. So we began to say, well, you know, kind of what are we doing here? So we looked at the reasons for people who didn't get steroids. So this is October 2011 to December 2012. Almost 3,000 infants born at those gestational ages at 19 sites. 91.5 received at least 1 dose of betamethasone. 80% received a full course, 20% received 1 dose BMZ. 40% received their first dose at the referring hospital. The mean interval from the last dose to delivery was 144 hours. So we also started talking about the sweet spot, right? I can guarantee you that every woman in this country will have steroids before premature birth. I'm just going to give everybody steroids at 22 weeks, right? That's not the right approach. You have to get it in the sweet spot. You want to get it within a week of delivery. That's the tricky part. And so we do have some data. I think, Jay, you have a slide on this, so I'll leave that alone for now. Only 8.5% essentially did not receive steroids before birth. Of those, 72% were born less than 2 hours after a hospital admission. Now, I think we might disagree between 12 hours and 6 hours, but I don't think anybody really agrees that steroids 2 hours before delivery is going to do much good, right? So most of the women who were missing were what we call stop and drops at my place. 11% were admitted, but were not expected to deliver, and 8% had a lethal anomaly, okay? Doesn't matter what you do for that poor baby. It's not going to live. You don't give steroids to a lethal anomaly. And that's not something we talk about in the data very often. So only 4% were system errors where they were ordered and not given. So where's the problem, right? We've got good data showing you that our steroids are being given everywhere. The ones who aren't getting it are either coming in very rapidly or they're lethal anomalies. So here's the issue. Here's the birth certificate data from those same hospitals in the same year. Ohio did something where we launched what we call Hospital Compare, and we started reporting on ANC use through the birth certificates publicly. And at that time, you can see the quality of data went up substantially just from publishing rates and using the data. So when people thought the data started to matter, they started putting effort into having higher quality data. You can see here, this dotted line here is where OPQC started, and we got a little more bang for our buck here as well. But here's the 90 mark. This is around 70%, right? But yet when we got high quality data, we know it's much higher than that. And we knew that most of the non-adherents were explainable. So this is a big danger with using the birth certificate data, especially if nobody is using it, publishing it, and thinks that it matters. So data source matters. Administrative data on steroids is not good when compared to the gold standard of hand-collected data. Administrative data is cheap, it's complete, it's uniform, and it gives unreliable answers. With one exception. It's fine for internal tracking, right? So if nothing else is changing in your system and you want to see if something you're doing is improving things, you can use it to track internally. You just can't use it to compare yourself to anybody else. So, in terms of a cheap and easy way for hospitals to get feedback on what they're doing, if it's working, terrific. But if you want to compare yourself to St. Elsewhere, not so great. So with high-quality data, we now know that the barriers are getting women to the hospital on time. So when I put these slides together, I was a little nervous about getting in front of this crowd and saying that, and then Dr. Kotelchuk got up this morning, and I just felt this wave of relief. That's exactly right. It's about getting women to the hospital in time. Is it recognition of the symptoms by the patient? I don't know. Is it transportation barriers like we talked about today? Is it index of suspicion on the physician's part? We don't necessarily know what those barriers are, and so I would echo Dr. Kotelchuk's plea to get more information on that. But we also know that birth certificate quality on this issue is currently poor and has potential to improve. It's not that it couldn't work, it's that it doesn't work. So that we have the potential to get all the good things about birth certificate up to speed with a little bit of work. And that was one of the sub-projects that OPQC did undertake during the steroid project. This happens to be a algorithm from Miami Valley Hospital, and they did give me permission to use this because we don't usually identify stuff from OPQC. I don't know how well this is showing in the back, but basically they talk about all the different ways to sort of ensure that the birth certificate data is quality is higher, and trying to improve the quality of the birth certificate data. So, recommendations. All neonatal steroid quality reports should clearly mark the data source so that the quality of the data can be evaluated and the limitations can be noted. Hospitals should continue to review patients less than 34 weeks who do not receive steroids until birth certificate data is satisfactory. I do see a day, especially if Leapfrog and JCO and all these other groups are going to use birth certificate data, people will start putting a little more resources into having higher quality data extraction. I also think the EMRs potentially have great promise for this if we can get the Cerners and the Epics and the other groups to start having standardized pulls of steroid information in their packaging, in their standard software packages. We can get very accurate information, but we're not there yet. So until that time, we really need to be able to differentiate where our reports are coming from. And then lastly, efforts to improve administration of steroids should focus on getting women to the hospital sooner for preterm birth. 72% of the missed opportunity group found in women less than 2 hours after arrival to the hospital. If we have 6 hours, if we have 12 hours, if we have 24, the more is the better. But I think, and Jay, you may talk about this more because this is more your area, but there's an opportunity for finding finer ways to try to predict who should come into the hospital and who shouldn't as the first step, and once they're in the hospital, what do you do with them? I believe that's my last slide. Yep. So I'll turn it over to you.
I don't know very many of you here. I'm Teri Kiehn. I am the Operations Director for the Women and Newborn Clinical Program at Intermountain Healthcare. And I'll forward here, no conflicts of interest. I won't read what we do or what our vision is, but just for those of you not familiar with us, we're an integrated healthcare system basically in Utah, but we do have one small hospital up in Idaho that we still own. We have 20 birthing facilities and one children's hospital. Our birthing facilities, our smallest one did 29 births last year, all year. And our largest do about 5. So as you look at our protocols, we're trying to develop a process that works for our largest facilities all the way down to our smallest facilities. So it's complicated, but we found that if we're really going to do comparisons, we have to hold them to the same standard of care. And they sit on our teams also. So how our teams work is we have our healthcare leadership. Then we have our Clinical Program Guidance Council that is co-led by myself and an MFM physician. Then we have what we call our development teams, our practice teams, and our standards teams. These are the teams that do the work. Our standards team consists of our managers. Our practice team consists of our frontline nurses. Our development teams consist of our providers and the leads for our practice and standards teams. So when we're developing protocols, policies, any processes, everyone sits on those development teams, and I would challenge any of you to come and sit at these meetings and know who's who, because everyone has the same say. So whether it's a nurse, it's one of our administrators, our respiratory therapists on our NICU side, everyone gets input into what the capability is for this process, and it really helps us get it to the end of the row. So these teams, individuals meet from all our facilities on these teams, and then their task is to take any protocol, any order set, whatever we're going to develop, take it out, get input, and bring it back. So then when we push it out, we don't hear, wait, we didn't have the input, that doesn't fit for us. And the reality is having the nurses give that input, because they're the ones that really have to make it work. So don't want to repeat what everyone has already heard, but we found birth certificate data totally inaccurate. It just didn't work for us. So what we did is we looked at our data. We utilized our nursing documentation and our pharmacy data combined to really look at what our rates were. We don't have electronic provider documentation, but we will have for the fall, and that's hopefully going to make our set even more robust. Then we created really detailed reports. So you'll see some of the examples of those so that we can tell immediately. The next day, the manager can go in and see who was on that unit the day before, who got steroids, who didn't. They don't look at it every day. We look at it monthly. But we review them by our system leadership, our managers. It's available to anyone on that unit to go in and do some drill down. And our next step is to include it on what we call our quarterly provider data reports. Brian O'Sheryl helped create those when he was at Intermountain. And I said, next step, my analyst called me this morning and he said, all right, you want it in there, it's going out today. And yes, it is. So now, as of this morning, the new provider report that went out for the first quarter of this year will include comparisons for the providers, exactly what Jennifer was talking about. How do I stand in comparison to our facility, but then how does our facility compare to our region and to the system as a whole? So we started pulling our data, and it was interesting. Russ called me in December and said, do you want to talk on this? I'm like, yeah, we're doing great. I think we are. And then I called my analyst, and I said, pull it really quick and see what it looks like, because we hadn't looked at it. We were over 90%. We're doing good. Let's move on to the next thought process. So he called me in the end of 2013, and when we went back and looked, we thought, oh, we have some opportunities to improve. And this is with precipitous deliveries included. So then we started looking at it. I said, well, let's go back and let's drill down as a team. And we looked at it with the providers and said, all right, what percentage of our patients are getting full steroids? That's the blue bar. Partial is our purple bar. And no steroids is the green bar up there. Because really looking at where do we have opportunities? And that's what we do with it. Intermountain. We have very robust data. We have disparate data systems, but it all feeds into a data warehouse in the background, and then we can pull it out and do some analysis. And those of you that don't have that capability, I really encourage you to work to create that, because that what allows us to do some really quick quality improvement, get the data and get it back out to somebody. So then, as we did drill down, what Jennifer did also is we looked at it and said, all right, well, where are we having problems? And where we found our problem was less than 2-hour deliveries. Patients were coming in and delivering within 2 hours. So when we pulled those patients out, still had a little bit of a drop in 2013, but doing significantly better, like we thought we were, and I'm glad that we are. Then we started looking at it by facility. These over here are our tertiaries. And then we weren't sure who these other facilities were. We're saying, well, we have some really small numbers. And said, well, let's look at it a little bit deeper. So then we went by, here's our tertiary centers. If you came into an Intermountain tertiary center, you had a 98.1% chance of getting steroids initiated. If you were at our level 2 facilities, 90%. And if you were at those poor little rurals, only 5 patients, but 60%, they don't see very many. The goal, of course, for them is to get them to us in our tertiary centers. We also created what we call our provider reports. These are accessible very, very quickly, and I've tried to blind it carefully so that I don't have patient or provider information. But if you look over, here's our facility, the counts, and these are the provider names, what the percentage of steroids is. The really nice thing, my analyst pulled this to 32 weeks. It should have gone to 34. But we're able to, the minute we pull this up, if you click on this patient number right here, it'll drill right into the patient record. So it isn't cumbersome. You can click on it, go right in. But this report basically tells us the facility, the provider, the patient ID, gestational age at delivery, delivery date and time, and how long they sat in L&D. So it really tells us really quickly where our opportunities are. So how did we change our practice? As I talked about, we involved our stakeholders at all levels in our planning process. I meet a lot with our small facilities. I do rounding. I go out there. They're pretty close. Utah's not a huge state. But I sat down and talked to them, and our nurses and providers both said, we need some help. We had some great order sets and other processes out there. But the nurses identified a need. You know, we know they're supposed to give steroids, but we really don't know why. Like, oh, okay. That seemed pretty basic to me that has a NICU background, but they really wanted to be able to have a script. This is why it's important. They may only need to give them a couple times a year, and to be able to convince, we have a state where vaccines are, well, we don't do this very much, and you know, an injection of steroids was a little frightening to some of the patients, and so the nurses wanted to have a script that said, this is why it's important for your baby. So that was very, very helpful for them. So we developed that implementation plan, that education program, the materials, and the measurement and reporting tools. And then we want to provide the data on the compliance from our internal trusted data sources. Because again, the big thing is, you know, the data is wrong, that's not my patient, and really have those trusted sources. And our doctors really trust us quite a bit. So that's the piece, is make sure that if you're providing that data back, that it really is trusted data. So what tools did we use? We have a fetal fibronectin protocol, a preterm labor order set, real-time alerts for nursing. Not as helpful in the bigger facilities, real helpful in our smaller facilities. And then we developed provider care process models for PROM, preterm labor, and we're in the process of developing one for preterm birth. So here's our order set. Right here you can see it has antenatal steroids right on it. This is a requirement. All our facilities use this. They know right away what they're supposed to do. Then our nursing alerts, I happened to grab the one, this is our FFN one. So the minute the nurse checks preterm labor less than or equal to 35 weeks, the FFN pops up and says, just a reminder, you need to do it. It's not a hard stop. We don't want to stop them if mom's going to deliver. They can click OK, it goes away. If they want more information on it, they click up here, get the information as to why they need to do that. And now she's clicked through that, but we really need to have good data. So we want to ensure when the nurse goes to archive or close down the documentation, if she clicked through it and didn't answer a response, it reminds her, you need to document steroid, antibiotic use, the rupture membranes, etc., so that we have really good data, because if she doesn't put it in, we can't obviously take it back out. So we have a care process model for premature rupture of membranes. Again, our providers in our small facilities really, they don't run across it that much. We're working on building this into our new order sets, and with Cerner, we're going to build it right in so the algorithm goes right through. But you can see it just steps them through. 25 to 31.6, we have a definitely give the steroids. 32 to 33, they need to consider it, and then there's more information on which patients. And these are all available on our outside externally too. We make these available to anybody. We just developed a care process model for preterm labor. And again, right there in the algorithm, here's what you need to do. And then we started adding the whys. Again, just to help the fact that here's why you need to do it, and then explains the the medications there for the smaller facilities. So what were our challenges? You've heard this over and over. We've heard about this from our rural facilities. The recognition of the patients with those early symptoms of preterm labor, kind of hesitating to get in. We have large geographic distances in our state, which is why we have some facilities we allow to do 29 births. It's 3-4 hours to the next facility. If we don't let them do them, the patients are going to show up anyway, and they're not going to know best practice. Small facilities with minimal staffing, they have one nurse on sometimes. The provider's not there. If we don't have step-by-step what they need to do, it doesn't get done. So that was a big piece for us to really have it right there so they could follow an algorithm. Another area we found was transport between our non-Intermountain facilities and the medication documentation. Sometimes we were missing whether it was really given there. They might not have copied all the information off. You ask the mom, she's not really sure if she did it. Yeah, I did get an injection. I'm not sure what it was. And then getting feedback to the facilities and the providers in a timely fashion. If you cannot provide that feedback quickly, which is where we think we went down in 2013, we weren't letting anybody know how they were doing. So now we started providing it back this year, and we bumped up pretty quickly. You see how you're doing, it makes you think about it. But if you don't see how you're doing for 6-7 months, it doesn't make a difference. Within a month, we brought it back up again. So what have we learned? Involving everyone in the planning process. Again, considering scripting responses to those expected challenges. It made a big difference for the nurses to be able to say, this is why I'm doing it. The why to the providers and nursing staff. I'm a nurse, I can't emphasize enough to make sure that your nurses are really a piece of this process. They're the front line, they're the first people that come across those patients. A clear chain of command and processes for deviations. We've empowered our nurses. If the provider says, I'm not going to, and you really feel it fits that protocol, put it up the chain of command. It's really important. Again, what else have we learned? A real strong consensus with everyone involved. This is what we're doing. Here's how we're moving it forward. Initially, one facility pilot worked best with us. A real good PDSA. Trying to do it across 20 doesn't work well. We put it in one spot, move it pretty quickly, move it through, and then move it on to the next. And again, that feedback to the providers needs to be real consistent and timely. And at Intermountain, we really believe that if we don't wait till we get it perfect, we roll it out, get that timeline out, we do it all the same initially, collect the data, see how we're at, and we worry more about doing it the same than doing it exactly right. And we just emphasize over and over, every single member of the team has a primary responsibility to best patient outcomes through adherence to these robust care processes. Really important. So what are the recommendations? Same ones as everyone else has had today. The hospitals should continue to review those patients that don't receive the steroids and determine what those barriers are. Provide education to those referring facilities on the importance of steroids. Community education so patients are informed on the preterm labor signs and the importance of the steroids. Again, understanding that what those signs are and something can be done, and utilizing social media to bring to the public's attention the importance of steroids. It really, I don't know that we can scare them, but I think at least them understanding and getting that conversation going. We've had some great luck with social media. And anyway, there's our ultimate goal.
Hi, Scott Burns, March of Dimes. So this is fascinating. You guys were both great. So my takeaway in listening to you, so you had the Ohio approach where you said, we're just going to collect the data. We don't own you guys. You're all out there, and you take the data, and we're going to give you your individual hospital data, but we're not going to identify the other hospitals, and you see how you're doing. Then you have Intermountain, just correct me if I'm not getting this right. Intermountain Healthcare, you've got much more intensive approach. You've got all those cool algorithms that I don't know if those are public or not, but would love to see those.
They're out there. They absolutely are.
And you're collecting the data on your individual providers and the hospitals. And I saw, unless I wasn't looking at this correctly, very similar results actually, in terms of where you were. So I don't know if I want to do like a point counterpoint thing or whatever, but if you guys can just talk a little bit about that, because for those of us that are contemplating doing this with groups of hospitals, I mean, what do you suggest?
So I think there's one key piece here that's very different is, and correct me if I'm wrong, Utah is a network where they have a common leadership, they have a common core value, they have some financial interests. We've got, in Ohio, 20 different hospitals who have essentially nothing to do with each other. There's nothing joining except for they're in Ohio. And so the ability to control what happens in those hospitals, you have to ask, you can't force. And so, the carrot or the stick depends a little bit on whether you can even have a stick.
She's exactly right. So we're a system. We all have financially a big interest in doing it right. So we're looking at developing a quality collaborative in Utah, and it's going to be similar to what they've done. We're going to present what we've done across the whole state and say, here's what the results we've done in Intermountain by this process. We know other people have other processes in place. Let's all sit down and see almost what Ohio's done. Here's the different processes that you might be able to do depending on your capability of data sharing.
What percent of the delivering hospitals do you have in your?
58% of the deliveries are done within Intermountain Healthcare. Mm-hmm.
Hi, I'm Joel Segre here on behalf of the Bill and Melinda Gates Foundation. Both of you guys talked about really impressive sort of quality improvement efforts related to steroids. Are steroids easier or more difficult or somehow different from other quality improvement efforts that you take on in the perinatal space?
So I think so, yes. I think one of the key things is that they've been around and there's general acceptance that they're a good thing. So for example, when we think about progesterone, which is the newest, latest, greatest, there's much more disquietment. I'm not even sure that's a word. People are a little, there's still a little bit of unease with the data. We don't know all the answers to our questions. It's relatively new. Some people really want to wait for years worth of data, whereas steroids have been around for a long time now, and there's a fundamental sort of acceptance of them within the system. Most of the practicing docs now grew up with them. So I think there is sort of the age of the technology, if you will, that it makes it easier.
The other piece with it is it really doesn't impact the provider's lifestyle, et cetera. We were the other night talking about it related to the 39 weeks. The 39 weeks had a huge impact on provider lifestyle if they weren't able to induce because they were going out of town, et cetera. This is just easier to convince people because it's the right thing to do, and there's good evidence out there.
And you can give a phone order for it.
Yeah, you can.
Jay Hines, Ohio State. I just want to get back to Scott's point, which got me up. I think the commonality is the collection and feedback of data. I'm going to made some notes that I didn't think to make slides on, and forgive me, New York and California, if I'm saying you're doing it differently. But we work together, those three states, in a CDC collaborative, and we all have the same goal around 39 weeks, or whatever we picked, it would be the same. And the CDC brought us together so we could talk about stuff like this. What Ohio does is quality improvement intensive. We connect the individual hospitals with quality improvement coordinators who have drunk the Kool-Aid, we call it, of the IHI, and they work individually with the various hospitals who know that they are above or about or below average on the last monthly call. So it's very QI intensive, and it's based on feedback of data. What I understand New York does, and maybe Texas also, is they put more of a financial incentive on that. We're not going to pay for it. Ohio has not yet done that. And maybe we will, maybe not. I understand California, Jeff, to be a state where you flood the public media with data so that anyone who even has any awareness at all can figure out that this hospital has a better rate than that hospital. And you don't do as much QI, or you don't withhold payment, or maybe you do, I don't know. Anyway, there's lots of different ways, different sticks, but the commonality is you collect the data and you feed it back quickly to the people who use it, and then you create some environment where people feel like I'm going to be embarrassed, or I'm not going to be paid, or I'm going to be whatever, called out. And somehow you have to do that. You have to work with it. But I think the commonality of the quick data analysis is really what makes it all work.
Bill Sappenfield, University of South Florida, Perinatal Quality Collaborative. Excellent presentations, very, very helpful. In Ohio, one thing you didn't bring up was variability. I mean, you do have 20 groups that are not well connected. Was there variability in Ohio?
And Jay, I'm going to defer to you. Do you have a slide on that in your?
I don't think you do. I don't
No.
have. Bill, see my slide. I don't think I could provide you with that data very easily. I can tell you there's wide variation, and that all hospitals got better than they were. We ask hospitals to compare themselves now to what they were before, and not to the hospital across town. We don't share that kind of data. But yes, there is pretty wide variability in the hospitals, depending on whether you look at birth certificate or hand collected data. The hospitals know how much variation there is. It's remarkable how much month-to-month or quarter-to-quarter variation there is based on the arrival or departure of a key data collection feedback person.
Bill.
Yeah, Bill Groban, Northwestern. I just want to sort of respond to the question about, is this different in terms of a QI sense than other QI projects? And I think, and I've been thinking about how I'm going to say this. I'm not sure it's going to be clear, but I'm going to hope it is. Which is that I think from a principal perspective, do the tools you use in terms of QI, do they have the potential to work for this? I think the answer is yes. But I think this is a fundamentally, and this goes back to something that Dr. Tooley said, a fundamentally different concept than elective early delivery, universal folic acid, those are denominators that you know from the start. Pregnant women, they should universally be getting folic acid. Anyone who doesn't receive it is a miss. Something has gone wrong. Elective early delivery. Before you do the elective early delivery, you know it's an elective early delivery. After the elective delivery is done, you knew before it was an early. Preterm birth, we do not have that capacity. So a miss, if you will, it is not entirely clear that that is a true functional quality miss. And it is really important because there is an offsetting, there's a balance here, which is to say there's one way to get to 100% in everyone, and that's to give every pregnant woman steroids. And then we'll have every hospital who is total success. But I don't think any of us at this meeting would want that. And so that introduces a nuance, as I think Method said, which is, I think, an incredibly important thing that we need to grapple with and understand that the denominators we use, delivery at 34 weeks or prior to 34 weeks, that is something that is unknown at the time you are interacting with the patient, which is very different from folic acid, which is very different from elective early delivery. And that is a really important thing that we should be thinking about at every moment when we're thinking about this question, because we don't want a world where pregnancy is so medicalized that every person who comes in and says, I have pelvic pressure, receives steroids. So that's all I wanted to say.
Thank you.
I think I have a related question. Are there ways that you can determine whether you are changing practice or changing reporting? And not, I don't mean it to sound like there's so much intention around but
it's a superb question. So I'll give you the example from the 39-week project, which is we actually looked at that in a fair amount of detail and published on it. And the answer was no, we were not changing reporting, we were changing practice. And this project's a little harder to say. For this project, I would argue for a large piece of it, we changed documentation and it's not documentation in the medical chart. We changed our data source and therefore got better quality data. And once we had better quality data, it became less of an issue. So, what the progesterone project for us is going to be, I don't know in terms of practice, but my guess is that it's going to be more practice change than data change.
Because the challenge too,
Yeah, go ahead.
is also, and there's a question behind me, not to butt in. But it gets back to the issue of who's coming in with true labor. So your denominator is very hard to get control of, and then putting quality around that as well.
Yeah, I'm going to hold the additional questions only because the next session is similar in content, and some of these points may be either covered there or we can raise them again at the end of that session, and I'll try and get us back on time. So let's thank our speakers again.